Our next speaker is Dr. Zhongxing Liao. Dr. Zhongxing Liao from University of Texas MD Anderson Cancer Center. She did her medical training at the Hunan Medical University in Changsha, China, and her residency training at MD Anderson. She is professor and clinical medical director in the Department of Radiation Oncology at MD Anderson. Dr. Liao.
Thank you so much, Dr. Keller, for inviting me. Also for, actually, you're the second person pronounced my full name correctly. I'm really impressed. And thank you very much, Mr. Tatar, to organize this symposium. I think the symposium so far has been very nice and very informative. Actually, I learned so much from Dr. Ferguson. So Dr. Ferguson, actually, his talk set up a very good stage and a very good introduction to what I am going to focus on, which are the population of lung cancer who cannot have surgery. So what I'm going to talk about is how to use molecular targeting and physical targeting in personalized treatment for locally advanced non-small cell lung cancer, for whom most of them cannot go through surgery. And in a way, it's also a designer's radiation treatment for those patients. So for locally advanced non-small cell lung cancer, you can see in this pie chart that the lung cancer patient, when they got diagnosed initially, about 25 or 30% of them are stage 1. Those patients typically goes to Dr. Ferguson. And then another 25 or 30% has usually stage 4 disease, and those patients, the primary treatment would be systemic treatment, including standard chemotherapy, molecular targeted agents, and the combination of palliative radiation or palliative surgery and those kind of things. And then the rest of almost like half of the non-small cell lung cancer falls into locally advanced non-small cell lung cancer or surgically unresectable or inoperable non-small cell lung cancer. Those patients, either for their medical comorbidity or for their disease of the stage of the disease, they cannot go through surgery. In those cases, then the standard treatment is a combination of chemotherapy and radiation therapy. Radiation therapy here replaces the surgery in terms of local regional treatment. That's how important radiation is for non-small cell lung cancer. Of course, you can see in this small table, we still have a long way to go to improve outcome of this population because their overall survival is still pretty poor. And after decades of study and randomized trials, we now learned that for locally advanced non-small cell lung cancer who cannot go through surgery, concurrent chemoradiation therapy is better than sequential chemoradiation. So that becomes a standard of care. So this graph shows you the meta-analysis with the number of collaborative group randomized studies looking at concurrent chemoradiation therapy, meaning that chemotherapy is given simultaneously with radiation therapy during the course of radiation, and versus patient who received chemotherapy first and then have radiation therapy. You can see there's a overall survival benefit in patient who received concurrent chemoradiation therapy. Even though the benefit is not that great, it's about 5%. However, for non-small cell lung cancer, that has been considered a significant improvement. So concurrent chemoradiation therapy is the standard. So how can we further improve in the outcome of this group of patients? One thing we know about non-small cell lung cancer patients is they have very high failure rate decently, meaning that cancer spread out to outside of the chest and to other organs. And they also have very high rate of local recurrence after only concurrent chemoradiation therapy, unlike surgery. Because surgery, you can remove the bulk of the tumor. Radiation therapy, really, you try to kill the cancer cells. However, there are cancer cells become very resistant to concurrent chemoradiation therapy in terms of standard treatment, and then they recur. So you can see if we locally, we have tumor control locally, meaning that patient has no local recurrence after chemoradiation therapy, you can see their survival is 24% at 5 years. But if a patient has local recurrence, then their overall survival will drop dramatically to 6%, meaning that local control for the tumor is very, very important, and that's why we have to have surgery or radiation. So how can we increase the local control in this group of patients who cannot have surgery? And so one thing we always talk about in radiation oncology is to improve the therapeutic ratio, meaning that this blue line is the probability to get tumor controlled without a recurrence. And this probability is the complication the risk of complication as a result of the treatment, as like a concurrent chemoradiation therapy. So to increase the therapeutic ratio, what we need to do is to move the blue line to the left or move the yellow line to the right. So we have a wider window to give treatment. In that case, we can increase the therapeutic ratio. So one way to do that is to enhance radiosensitivity of the cancer cells. And the chemotherapy, actually, originally, when we give that concurrently with radiation, is with the intention of sensitize the tumor cells to radiation therapy, which has proven to be more effective than sequential chemoradiation therapy. And nowadays, of course, with the advancement and the improvement of our understanding of the cancer cells in their genomic alteration, gene mutation, and tumor markers and things like that, that has opened a very new era in terms of how to sensitize cancer cells to radiation therapy and other chemotherapy. So in the past, what we usually categorize non-small cell lung cancer patient is very rough, squamous cell carcinoma, adenocarcinoma, and other type of histology. Nowadays, we have more detailed characterization of cancer cells based on their cancer cell gene mutation. For example, most commonly expressed in cancer cells, EGFR, KRAS, and now come to the paradigm is ALK and other type of tumor markers. And also one important thing is those genomic alteration or mutations are druggable, so you can design a drug actually specifically targeting those tumor cells. So given using EGFR as a example, we have now, commonly used a number of EGFR inhibitors, like Erasa, Tarceva, and Cetuximab or C225 in different clinical trials. And those trials are, usually stage 3, stage 4 patients who cannot have concurrent chemoradiation therapy. So for chemoradiation, we first started with the animal study using C225 or Cetuximab with a combination of radiation therapy alone, no chemotherapy. So you can see this is the control. This is no treatment. This is only treatment with C225 once or 3 times. And this is radiation only for tumor. This is radiation plus 1 time C225 versus 3 times for C225. And then those a little square is how big the tumor size and how long it takes the tumor to grow into certain size. So you can see if you give 3 times of CT25 with the single dose radiation, you have a very large delay of tumor growth to a certain level, which means that combined together, CT25 really enhanced radiation therapy. Based on this preclinical finding, there's a very successful head and neck phase 3 trial using CT25 and radiation therapy, which demonstrated the overall survival benefit. And encouraged by those great findings, radiation therapy oncology group, RTOG group, has started a phase 3 trial using CT25 and then combined with concurrent chemoradiation therapy, followed by consolidative CT25 and chemotherapy concurrently with the CT25. So in this trial has been published, and this trial has been compared with another RTOG trial, which is 9410, which is the trial actually in the United States performed to establish concurrent chemoradiation therapy as the standard of care. And in that trial, we had 3 arms. The standard arm is once-a-day radiation induction chemotherapy followed by radiation alone. And the comparison arm is concurrent chemoradiation therapy once a day, standard dose versus hyperfractionated, which is twice-a-day radiation therapy to a higher dose. And you can see that the current with combined with the CT25 concurrent chemoradiation therapy, the median survival time is 22.7 months. Just to give you some historical background, which the median survival time in this group of patients typically is about 12 to 15 months. So in the way, this is a great improvement compared to our historical control. Toxicity is very minimal, and 2-year survival also compare favorably with our historical control in other phase 3 randomized trials. So currently, there are a few published Cetuximab or CT25 combined with radiation therapy alone. Those are all like phase 2 trials, and you can see the patient number included in each study is not really that great, and the radiation dose and their outcome. I have to say, with the radiation alone combined with CT25, I think the median survival time is better than standard concurrent chemoradiation therapy, but we could improve upon that. That's why I think concurrent chemoradiation and Cetuximab chemoradiation and CT25 might be the way to go. So you can see this is it's quite consistent that with the combined concurrent chemoradiation therapy and CT25, the median survival time is about 20 months to 25 months. So based on these single-arm phase 2 studies, RTOG actually just completed a trial, which is RTOG 617. In this trial, this trial had 4 arms. The one primary goal is to see if increased radiation dose will increase patient survival as a result of increased local regional control. The other one is to objective is to see if we add CT25 to concurrent chemoradiation therapy with low dose or high dose, if that will increase patient survival. So this is their primary objectives. Compare the overall survival between high dose versus standard dose and with and without CT25. So the high dose versus low standard dose information has been released, which I will touch base a little later, and we're waiting for the results on the outcome of patients who treated with and without CT25. Another commonly used EGFR inhibitor, of course, is Ilotinib and also Iressa. You can see from preclinical study, both the Tarceva and the Iressa had radiosensitization effect. That's why we had another study to study Tarceva with a combination of concurrent chemoradiation therapy. This is the schema of the trial. Concurrent chemoradiation therapy was given with the standard dose radiation, and the Tarceva was given in the days when chemotherapy is not given. And the patient all received consolidative chemotherapy. In this trial, we enrolled 48 patients. All of them are stage 3. They are not surgical candidate. The standard recommended treatment in this group was concurrent chemoradiation therapy. Majority of them are adenocarcinoma. One limitation of this study is that the patient did not have a gene test, mutation test before the treatment. So it's unselected in a way. So toxicity is very, very favorable. You can see very low toxicity. And also, the commonly associated skin rash with the Tarceva had a predictive value to median survival time. You can see, like, if a patient had grade 3 or greater skin rash, their median survival time is the longest versus a patient who has no very minimal skin rash. And short-term outcome is very encouraging. 1 year survival, 85%, and dismal metastasis-free survival at a year is 80%. This is quite good for non-small cell lung cancer in this group of patients. This is one case of, in that study, you can see patient presented with a large bulk mediastinal lymph node. I'm not quite sure even after chemoradiation, Dr. Ferguson can resect that. So this patient came to chemoradiation therapy. He was treated with, on this trial. You can see 3 years later, he remained to be without evidence of disease. Some early publication on the, either ERASA or Tarceva and concurrent chemoradiation therapy on lung cancer is also listed here. I can see that, the results are still very premature, and we're still waiting for either larger study or maybe finally a phase 3 randomized study. I just mentioned that, in non-small cell lung cancer, we have EGFR, which I have just commented, and we have new, new markers. And we also learned that a patient has mutations in their tumor cells. If they're mutation positive or if they have that target in a way, then those targeted agent works better. I mean, logically, if you think about that. If you don't have that target, you don't shoot with this bullet, right? So actually, currently, this is one of those slides to show EGFR mutated patient treated with Tarceva and ALK mutated patient treated with ALK inhibitor quercetinib. And there is a 70% partial response rate. Based on this, and currently, RTOG actually just had approval of a phase 3 trial by CTEP NCI to stage 3 non-small cell lung cancer. So those patients will be, all patients will have a test. If they have EGFR mutation positive, then they will randomize to either use, Tarceva versus no Tarceva, but all with concurrent chemoradiation therapy. The same design for the ALK, translocation patient. However, when we talk about all these molecular target inside the tumor, you can see, if you have a whole tumor, only proportion of the cancer cells express those target, and only proportion of the cancer patient, their tumor express those target. So there's a bigger picture there. And a majority of patients actually do not have a known druggable target. So those patients actually really are, in a way, it's the primary component of our big picture for concurrent chemoradiation therapy. So our patient usually comes with this type of presentation. I don't know whether you can see the whole body picture on the large screen. This patient is a very young patient, large right lower lobe tumor and very peripheral tumor and extensive mediastinal lymph node, subcranial, paratracheal, large like paratracheal, and also supraclavicular lymph node. So those are patients typically come to chemoradiation therapy. So for chemoradiation therapy, in terms of the target, radiation is the target. Radiation is the one to target the large target. Including the molecular and whatever is composed of the tumor. So this is what we talk about when we target radiation therapy. Again, come back to the, to the principle of radiation therapy. We want to increase the local control, but we do not want to increase the toxicity, because toxicity do kill patients. And going back to the RTOG 617, as I just mentioned, the primary objective are two. One is to compare the overall survival between high dose versus standard dose. Why we want to give a high dose? Because we know the dose we give to patients right now, the standard dose of 60 gray, we have 50 to 60% of local failure. So one logical way would be increased radiation dose. So this is the rationale for RTOG 617. However, surprisingly, these the short outcome like at 1 year, you can see actually the curves are flipped. This is 74 gray, high dose. This is low dose. So high dose arm actually had a worse survival. Why is that? So we are trying to understand. But one thing, this is actually just reported in ASCO 2003. One small details that was reported caught my eyes because I focus a lot of my research and clinical work on toxicity. Because in these two arms, you can see the high dose versus low dose arm, the cancer-caused death is the same. So, which means, patient died of lung cancer, it's the same on both, on two arms. So what did they die of? What did the high dose arm patient die of? Not cancer. So what they had a high dose radiation therapy. And so what, I guess logically people would think this patient probably died of toxicity. And further analysis of the data from this trial showed that if a patient had their heart received the low dose, low volume of to the 5 gray, meaning that the amount of heart get 5 gray of radiation or less if they had a lot of heart spared of that, or 50 gray, V50 is lower, then they had better survival. Meaning that if you can stay away from the heart, then patient had a better survival. I believe this should be very logical or simple for all the physicians because, of course, heart is a very important organ in a patient, in a person's life. I still remember when I was doing my residency, and my chief resident was telling me how to distinguish true emergency. He was telling me if a patient come with a heart problem, you go deal with that right now because patient may have a heart attack. And if a patient has constipation, which means the bowel stop moving, that's okay because patient probably is okay. Because if heart stops, patient is going to die. So I think this is a very simple principle, but for years and years, I believe radiation oncologists probably kind of overlooked this very important issue. So another actually very interesting finding from this analysis of this RTOG 617 is that if a patient had a deviation in their radiation therapy plan, meaning that they did not meet the dose constraints, because all the normal organ will have a certain limitation, and there is a very clearly laid out protocol. You have to keep those doses below those level to be safe to give the radiation. So if you, from this you can see if the patient, their plan had a deviation from the dose constraints, they have 70% increase of dying. So this is how important the quality assurance and the stick with the protocol is to radiation therapy. And also, recently there was a very interesting publication in JNCI. In that publication, what they did is that they summarized 8 studies used radiation therapy. And they looked at radiation quality assurance deviation versus no deviation and their impact on overall survival. Very strikingly, you find that 8% to 71% of patients had a deviation according to RTQA. And then if you look at the hazard ratio, if patient had a deviation from their treatment, radiation treatment, their risk of death is 74% increased. Their treatment failure is about 80% increased. So, which means that if you don't follow the protocol, you're going to fail the treatment. So the effect size from this analysis surpass those typically seen in very successful phase 3 trials. So that's why a lot of times you don't see any good effect with any good treatment in a phase 3 trial, even though you see that in a phase 2 trial. Anyway, so this is another way to demonstrate how increased risk of death when patient had a deviation from the treatment and increased treatment failure when they had a deviation from treatment. So that's why ASHA actually now is starting a practice accreditation program with the 19 standard from the treatment, from the staging, processing, all the standard, and until like the QA and the QM, all those kind of things, and to make sure, radiation therapy is designed and delivered according to standard. And we all know this case, and we do not want to see our own institution show up on New York Times with this kind of news. And one of the major side effects in radiation therapy is radiation pneumonitis, because we have to go through lung to deliver the treatment. And you can see, this is the dose distribution of radiation, and this is where the grade 1 pneumonitis start, infiltration. And then grade 2, you see a little more patient become symptomatic. Patient become cough and shortness of breath. You have to start steroids and inhalers and things like that. And then stage 3, patient could become O2 dependent. And grade 4 patient will be intubated. I have never seen a patient who developed grade 4 pneumonitis actually get reversed. So it's a really fatal toxicity if you're not careful. That's why I think in radiation, it's as important as to kill the cancer cells to make sure you protect the normal tissue. And pneumonitis is one of those fatal radiation therapy toxicities. And we know now radiation pneumonitis is highly correlated with the dose to the lung and the amount of the lung received the dose. So a simple way to do that is to reduce the amount of the lung received radiation and reduce the dose to the lung you have to go through. So how do we do that? That's where the advancement in technology in radiation comes into place. So one, we start looking at how to reduce lung toxicity, and the first thing we tried away from 3D conformal radiation therapy is intensity modulated radiation therapy. I believe our cancer center here in Dayton has the advanced technology, has been using MRT very frequently. So you can see using IMRT, just advancement in technology, nothing else, in the delivery of the radiation therapy, we were able to reduce, this is when we use like a 3D conformal radiation, our grade 3 pneumonitis rate was 25% at 6 months, 30% at 1 year, very high. This is severe toxicity. And when we just changed to MRT, we were able to reduce that risk from 25% to 10% or less. That's just, based on advancement of technology, nothing else. So this is something really is readily available and should be used, really used. And then you can see with the long-term follow-up, with the IMRT, with the 4D CT stimulation, survival is compared with the 3D conformal is significantly improved as well. And you can see that, actually the improved pneumonitis rate has sustained with lung follow-up. And another thing I just talked about is about the heart dose. From 617, now everybody has a renewed awareness of how important the heart is. So we went back to look at our institution's experience. You can see if you have higher dose to the heart versus lower dose to the heart, you have a better. The patient received the lower dose to the heart had better survival. No matter how high the radiation dose to tumor is, the heart dose actually had a strong prediction to your survival. And combine the tumor burden, which is the gross tumor volume, and mean heart dose, the mean dose to the heart, and the volume of the lung received 20 gray or greater, you can see if a patient, all three of them are below median, their survival is really pretty good. And if you have one risk factor, or two risk factors versus three risk factors, their survival is decreased gradually. So which means that we cannot control GTV. We cannot control when patients come how big their tumor is. What we can control is the heart and the lung dose. That's what we need to do in radiation. That's why we have to constantly improve our technology. That's why I think it's logical for us to think about proton. Why do we use proton? Because proton have a very low entrance dose. So it doesn't deposit too much dose when we go to patient body and before they reach the tumor. Also, after tumor, the proton will stop. You can see this line. This is the typical proton dose distribution. This is the depth in patient. You can see in the this is the percent of the dose the radiation will deposit. You can see proton has very low entrance dose, but at the depth, it will have a very high deposit of the energy, and that's what the dose, what we call break peak is. And compared to conventional radiation, for example, we use like 8 MeV like photons. The highest dose actually is about 2 centimeters below the skin, or 1.5 centimeters below the skin, while the tumor is usually about like 5 or 8 centimeters inside the chest in lung cancer. So, that's how, when you have a tumor, when you use proton, you can see after the tumor, there's no dose passing through the normal tissue. That's why it's logical for us to use proton. Just to demonstrate how proton can stop, this is this is a child, have the spine radiation. You can see when we use photon, all the doses spill over after the target. The white line is the target, so all the organ anterior to the target got radiation dose. But when you use proton, you don't have any dose to exit. And this is again another way to demonstrate that. This is the heart, and this is where the target is. You can see how photon go through like a bullet, and the proton stop. What we say like a baseball. When you catch it, it will stop. So in lung, you can see the advancement, the benefit as well. So the proton can totally spare the heart and control the lung. And the photon even use IMRT. You will have low dose spill over to the heart and to the other side of the lung. And nowadays, with actually more advanced delivering technology of the proton, you can see you can actually layer by layer paint a tumor to the dose you need. Of course, this is our proton center. We started operating in May 2006, and we are currently, average we treat about 105 patients per day. And of course, this is something we are really very proud of. And I heard that here we're talking about a proton center. I think that's the way to go. And another thing with our early findings in using proton, this is our pneumonitis rate with 3D conformal, mean dose, and the percentage of the grade 3 pneumonitis. You can see how steep the dose response is. With the IMRT, we were able to reduce that. With the proton, we further reduce pneumonitis rate. So this is something I think is very important. And now come back to the heart. Proton therapy, this is 3D conformal, the mean dose to the heart. And IMRT, the mean dose to the heart, and proton. Proton can stop at the heart. So this is something we constantly try to understand and try to make sure, the public and the insurance company actually realize this advantage of the proton. And furthermore, if you look at the patient quality of life, we looked at 5 major symptoms during the chemoradiation therapy. For example, fatigue, sore throat, the wound, all those kind of things. Basically, you can see this is 3D conformal. This is IMRT proton. Patient quality of life is much better even acutely compared to our traditional radiation therapy delivery method. This is our early report. This is not published, so please keep that confidential, I guess. Don't quote me yet. We are in the development of the manuscript. You can see this is our proton-treated patients since 2006, and our median survival time is 32 months. That's really very good for non-small cell lung cancer. And even with the 617, the better arm, the median survival is about 27, 28 months. So based on these very encouraging early findings of the proton, right now we are having a phase 2 randomized trial compare proton versus IMRT. So this is our schema, and this is how many patients we have enrolled. We're looking for randomized patients between IMRT and proton, and we're looking at local failure and pneumonitis. What we learned so far, we enrolled 223 patients to this trial now. We can see, proton even just use current passive scattering proton beam radiation. The heart is always spared compared to IMRT, and the mean lung dose is always spared as well. And also we learned that image guidance in radiation therapy, especially in proton, is very, very important. You can see this patient, at the beginning of the treatment and after one fraction of radiation therapy, he developed a consolidation of the lung, and then that created a cold spot in the proton dose distribution. So it's critical to have image guidance when you have proton radiation therapy, because proton still has high uncertainties in their dosimetry. And another extreme example is when patient had a large solid tumor, and then the tumor cavitate, and then you have overshoot of the proton. Because proton is a baseball, you have to catch it. If you don't have anything to catch it, it will go through. So that's why you have to have image guidance when you have proton treatment. And actually, I just came back from Philadelphia to here to participate in a workshop for the study chairs for RTOG 1308. Which is going to be a phase 3 randomized trial compare overall survival after proton versus photon radiation therapy in this group of patients. And what we're going to do is use concurrent chemo radiation. We are going to allow a dose range in terms of dose distribution, dose prescription for tumor, but we are implement very restrictive normal tissue dose constraints. Actually, the cardiac normal tissue dose constraints is only 50% of the current RTOG standard. So, I hope by the time you have your proton center, you can participate in this trial. Anyway, with a lot of uncertainties and questions in proton, proton center has been mushrooming. You can see, all those proton facilities. Like in US, we have 11 operation proton center. Now in the world, we have many operating. Japan, of course, has a lot of experience in Europe as well. And also there are ones, in planning. You can see how many proton centers are in planning. I guess we can add one more when you start planning here in US. And so, obviously there is a lot of research and a lot of benefit to be realized using proton beam radiation. Cost of the proton has been always a debate, and whether it's worth it or not, I think we need to have a long-term outcome. We cannot be short-sighted and just to look at the delivery of the proton radiation therapy. For patient care, the molecular target is a target. The tumor is a target. Inside a patient actually is really the whole picture. So after the treatment, their quality of life, whether they have to go back to the hospital, whether they have a recurrence or not, all those adds to healthcare cost. So I think, eventually, hopefully, we will have long-term results in proton treatment, and eventually we can make proton therapy as a standard in patients who have a good indication for proton treatment. So just a few cases to show you. The case I just showed you, 3B disease. This patient actually was treated with the first case on my randomized trial with 274 gray, and you can see that, that's how we treat it. Very large field, and he did very well after the treatment. He eventually developed brain metastasis about 3.5 years later. He is a very active, just like Mr. Tatar in Florida, and when he was on the board of many hospitals and things like that, and so he was diagnosed with this cancer. He was in Florida, and the physician told him, we're going to give you palliative chemotherapy, and you have 6 months. And he was not able, he was not ready to accept that That's the reason he came to MD Anderson Cancer Center. So up to now, I still communicate with his wife, and she keep on telling me if it was not Proton, there's no way, we had like another 3.5 years. Not long enough, however, it's much better than before. So this is another case who actually had a EGFR mutation, who was treated with proton concurrent chemo radiation therapy with Tarceva. You can see how big the tumor is and how extensive contralateral hyaline node, very large tumor, and then after treatment, 3 years later, still pretty good. And this is actually his 2011 scans. And of course, I want to touch based on a little bit on the technology component. The motion of the tumor is always an issue in radiation oncology. And traditionally, what we have done is to treat the path of the tumor. And this is how to show you how important the motion is management is. If you this is the dose. The red is the radiation dose you want to give to the tumor. However, when tumor moves up and down, you can see in part of the treatment, tumor is outside of the high dose level. So nowadays, what we do is we treat the whole path of the motion. However, that will include the normal tissue treatment, the amount of the lung you included in the radiation field. So what do we do now? We gate the patient. So we only give radiation when tumor is in certain phase, and that's the time we give radiation. Also, we can ask a patient to hold their breath so the tumor is not moving. So this way, you can save a lot of normal tissue. And all those advanced technology, I believe, has contributed to the improvement of outcome in this group of patients. Another actually aspect I want to mention very quickly is during the delivery of radiation, how to quality control the treatment. For example, we are accustomed to port films checking, and we don't usually do daily combined CT. In my mind, I think daily combined CT probably should be the standard. So this is one patient. You can see this is the reference, port film. You can see the tumor is here and the tumor. And then after the first day, this is the first day, you see how tumor is moved out. And then you can see, the tumor move, along with the tumor shrinkage. And then tumor eventually shrank. And you can see how tumor is, the cardiac contour, everything is not as you thought on the port film. So if you only use port film, because this is using combined CT, you can see the difference, right? But if you didn't use combined CT, what will happen? So this is the simulation port film, and you can see the port film. You cannot really tell too much. Maybe a little bit here, but you really cannot tell. So that's why volumetric image guidance in radiation, in IMRT, especially in proton, is critical. You have to have it. Otherwise, you're going to be kind of hampered. So, you can see how tumor shrink during the treatment without a CT scan. It's very difficult to appreciate that. So nowadays, what we try to do, we try to integrate functional image, biology, and all those things together. We use PET-CT for outlining. We use LANSCLC to try to avoid, functional lung and go through the non-functional lung. And try to combat everything. Also, very restrictive QA in radiation is very important. I cannot emphasize that enough. And normal tissue toxicity reduction is as important as prolonged patient survival. That's how I think how important it is. So in summary, I think non-small cell lung cancer, especially in locally advanced non-small cell lung cancer, remain to be a very significant hazard, very difficult to treat patients, and the treatment outcome still has a lot of room to be improved. And we have to use molecular targeting, physical targeting. Please think in patient as a whole person, not just a tumor. I think it's very important. And also the in radiation, for us, for our profession, advanced radiation technology is very important, and it's critical to make sure that we deliver the treatment safely with high quality. And eventually what we want to do is we want to develop biomarker to predict who is going to be resist to those treatment and to personalize their treatment. I believe Proton has great potential, and I hope I can eventually see your Proton Center up and running, and I would like to see that. Of course, all this work are, a team effort with all those supporting and colleagues working together, and also funding from NCI. And finally, I want to thank everybody for your attention and for the meeting organizer for the nice invitation.
Open for questions. I personally have one, being in radiation. You mentioned the median value of the V5. I was curious, what cut point do you use for your target dose when you create a plan for your V5 and V50 volumes for the heart?
You mean V5 for heart, not lung?
Correct.
Okay. This is a very good question. The truth is we don't know. Because what happened is, as I said, during all these decades of radiation treatment, and we kind of focused on the pneumonitis, we kind of did not pay too much attention in the cardiac toxicity in lung cancer. The major reason is that patients do not live long enough to develop like a cardiac toxicity, unlike Hodgkin's disease and the breast cancer patients. So in a way, we actually do not know what is a good V5 and what is a good V55. So the only thing we know is that if you use pericarditis as an endpoint, then V45 is one of those critical value. If you have V45 greater than, I forgot whether it's V45 or greater one, then I have the paper, I need to give that to you. But anyway, then you have 25 to 30% of pericarditis. V45, anyway, 30% I believe, but I will give you the paper.
I wonder if you could educate a poor ignorant surgeon about physics and biology in terms of protons versus standard radiation therapy. Is a rad regardless of the type of treatment the patient's getting? That's number one.
Actually, the proton is not a very high LET, like a very high LET radiation, meaning that their biological equivalence effectiveness is about 1.1 to 1. That's what we believe. However, when I showed you the spread, break peak, actually the RBE in that area actually is not the same, even though we always use the entrance area to compare to photon. So right now what we're doing is we convert the proton dose back to the photon dose. So one we correct the proton dose, use the 1.1 RBE.
And the other is thinking about chemosensitization. Is it similar for photons and protons?
This is a very good question. Actually, that's what we are trying to compare the normal tissue toxicity versus the tumor control in patients treated with concurrent chemo radiation using proton versus IMRT. Whether they are the same or not, we actually do not know. There is no animal study to test if the the radiosensitization with the proton is different from photon or not.
So, based on the RTOG trial, it raises a little bit of a conundrum in our minds as to what dose we should be treating our non-small cell lung cancer patients to. Mm-hmm. The high dose was not as optimal as the low dose, but not due to cancer control, but due to tissue toxicity. If you had your druthers and you treat a patient off protocol, what dose do you typically utilize?
Yeah, this is a great question. Even though after 617's results has been publicized and reported, so everybody says, okay, standard of care should be 60 gray. We have never used 60 gray. So, in the randomized trial, designed for the RTOG 1308, where we have the phase 3 compare proton versus photon, we give a dose range. So what we allow is from 60 gray to 70 gray, as long as you meet the normal tissue dose constraint. The key is you have to meet the dose constraint. So off protocol, that's what we do. We go, if we start from 70, then if we don't meet, we go to 66, and then we go to 60.
So try to go as high as possible.
Exactly.
Meeting the constraints.
Yeah.
Even though the high dose didn't prove benefit.
Exactly.
So can you use protons on peripheral lesions that move?
Yes.
So how do you do that? How do you track that?
Yeah, this is a very good question. We actually have gating in proton. So we ask patients to actively hold their breath. So, when hopefully the tumor has a minimal residual motion, and then we give the proton treatment. But I think, right now our challenge is that, our proton center actually now is about 7 years old. And so it's old technology already because we did not have volumetric IGRT on the proton. So that's actually, really limiting our ability to deliver like a very high dose SBRT to using proton. Currently, we are running a randomized study, compare proton versus photon SBRT in early stage non-small cell lung cancer. So the way we do that is we put a Photoshop, and then we ask the patient to breath hold.
How does that work then? If the tumor is moving down and your protons then aren't being caught by your catchers?
You mean the Photoshop marker? No. Actually, right now we use two types of proton beam. One is the passive scattering. So in the way, the passive scattering is almost like a photon. So you flatten the beam, you have a filter. So in that way, it's almost like just 3D photon delivery, even though it's proton. Because, you take advantage of the protons' physical and the symmetrical, advantage. So if you use like the scanning beam, then basically you just use you have to put the scanning beam kind of parallel with the motion, and then you can you can scan that.
I wonder if you could say something about, let's say, a patient who's getting SBRT as definitive therapy for a peripheral lesion, photon versus proton. You think it's a clinically effective treatment? If the patient develops a recurrence, is the pattern of recurrence similar, local versus distant, between those two therapies?
I don't think so. I think their failure pattern is very similar, and I have to say, using proton for SBRT is our experience is very limited. We probably treated maybe 20 patients, but using photon for SBRT, we treated more than 1,000 patients. So we have a lot of experience, and in a way, it's very difficult in SBRT setting, unless it's a centrally located tumor, to demonstrate proton's advantage. Because what happened is, right now, the photon SBRT technology has become so good, and a lot of cases you do not need a proton. I think proton, the major population really, have advantage, and the benefit really is the large tumor locally advanced, when you cannot, use photon to treat. Yeah.
You had a very interesting slide talking about molecular markers that we know about. And a lot of the molecular studies are done, time of biopsy, initial diagnosis. Occasionally we'll re-biopsy people. But I might be mistaken. I'm thinking that certain receptors, particularly the EGFR, can be upregulated during radiation. Can you speak towards that, and does that impact, in your experience, how systemic care is given concurrently and after treatment?
First of all, I don't think we have done biopsy during the chemoradiation therapy for EGFR. So we usually do, either we do that upfront, before patients start treatment. So during the treatment, it's very difficult to do biopsy. So I don't think, I cannot really say we have experience in radiation-induced EGFR expression and what is that going to impact on the outcome. Did that answer your question? That might be something. In stage 4, actually, they do that all the time. What they do is, they up front, they do a biopsy, to test their marker, and then each time, if there's a change of therapy, they do a biopsy again and see if there's a change. And you can see, some marker has been induced, and there's a transformation, and then, that's how you kind of constantly personalize the treatment according to their marker expression. That's how we did our so-called battle trial. Okay, thank you.